So start with a little bit of an introduction to ORCHA, a bit of our background, and then looking at the ORCHA Assured process, how we support from that compliance perspective, how that then relates to NHS compliance, looking at things like DTAC, going to a quick Q&A, and then after a bit of a break, looking at ultimately what the ORCHA ecosystem means in terms of market access, some of those opportunities around the world, and then hopefully wrap up on or before about 12 o'clock. So as a little bit of background to ORCHA, as some of you, I know some of you will know already, founded about 10 years ago. So Liz, our founding chief exec, was a speech and language therapist by background. If you ever hear her present at a conference or talk in a session, she'll always talk about her frustration in practice of only being able to see one patient at a time, and really seeing the opportunity for digital and digital health to support her patients, but that ultimately as a clinician she had no way of knowing what technologies were safe, what technologies were clinically effective, what technologies were data secure, all these kinds of things. So that's really where ORCHA was born out of. Over the last 10 years, from an assurance perspective, we've become most well known for establishing the world's most trusted quality mark for digital health. In the last 10 years, we've assessed over 9,000 technologies now, and delivered over 38,000 assessments across 12 different markets. But the figures that we're always most proud of and always kind of most delighted to talk about is the impact that ultimately that's having. You know, as I say, Liz's mission was always how can we help more people, and over the last 2 years over 620,000 people have gone to a various point within the ORCHA ecosystem, and I'll talk about some of those various components later, to search or access a digital technology. And we've confirmed over 120,000 products have been downloaded as a result of being in the ORCHA ecosystem, and ultimately that's 120,000 patients that we've been able to support. I mentioned supporting assessment schemes in a number of different markets, and over the last couple of years we've worked obviously most prominently in the UK, having worked with NHS England and NHS organisations for a very long time, but ever increasingly across the US and Canada, supporting national frameworks in mental health and a number of other areas, but then spanning across Europe and down into India, Australia, New Zealand as well, where ultimately typically we will support with developing these assessment frameworks in the first instance. How do we bring what we've learned over a decade to support the development of those new schemes, those new criteria? Firstly, to make it easier for the health system, for the providers to actually know, well, this is what other countries are asking, these are the criteria other countries are using, but also to make it easier for you guys as digital health companies, as innovators looking to access different markets, so that actually you're not going through completely different sets of hoops and hurdles for every market that you're trying to engage with. Ultimately, as ORCHA, our mission was to break down the barriers to the adoption of digital health. I always draw the comparison back to medicine, and in medicine we have a really clear, robust route for establishing, testing and delivering new treatments to patients. So from a trust perspective, we've got the MHRA and NICE that go through that approvals process. We've got a really clear route to make people aware that those new medications exist. They're made very easily accessible to patients through prescribing and over-the-counter medication, and there's a very clear governance through if there is an issue with a medicine. As ORCHA, we deliver exactly the same thing for digital health technologies. So establishing trust through those assurance frameworks, driving awareness and accessibility through our digital health library platforms, enabling the public to go on and search for a technology, or a clinician to go on and e-prescribe a technology directly to their patients. And then that governance route, providing continuous monitoring of those compliance standards. So we know digital health can be its own worst enemy, particularly from a compliance perspective, in that digital products tend to update, evolve, iterate, and actually, as ORCHA, what we have the ability to do is to monitor that and ultimately carry those reassessments forward every time a product is updated, meaning that as a system they can have the confidence that, okay, this product was updated last week, there's already been a reassessment, and we're happy that compliance is still valid. The process for that assessment is very, very simple, and this is something that I always like to talk about because having been through many an ISO audit and various other types of compliance and seeing how arduous they are, how much work goes, and ultimately how much work as a provider you have to do to achieve some of those, the ORCHA review is designed to be as light touch from your guys' perspective as possible, and our team do all the heavy lifting. So for an initial assessment, all we need is access to the platform in the way that a patient or clinician or ultimately end user would engage with it, whether that's via access codes, login credentials, that kind of thing. That then allows our assessment team to go through and conduct the assessment against all 350 questions that we're asking about a technology. Once a product's passed, scored an average of 65% across the 3 assessment domains, it then goes in to the ORCHA Master Library, and we then start working proactively with you on where can we push this out and drive some of that visibility. And then that continuous monitoring piece being the most important thing for trust. So every time a new version is released to an app store, in the case of native products, we will automatically detect that and triage a reassessment. For web-based platforms, it's not quite so easy, so we just ask people to let us know, but either way it enters that triage process. What review are we conducting? What are we actually looking for a product to be considered ORCHA assured to ultimately pass these standards? As I say, it makes up 350 questions in total across these 3 key domains. First and most prominently, data and privacy, arguably the hottest topic in digital health over the last couple of years, given some of the things that have come out of the US. But fundamentally for the global baseline review, we're looking for evidence of GDPR compliance. So what type of data is being collected and stored? How is it being stored, shared, accessed? Going into the granularity of things like the privacy policy as well. Looking at not only is it accurate, does it reflect the way data is being collected, stored from what we've seen by engaging with the product, but actually is it completely honest and transparent as well? I'm sure you've heard of a relatively high profile case earlier this year where when their privacy policy was inspected, it wasn't a case of it being necessarily overtly dishonest, but it was a case of it being not transparent about the potential data uses. So looking at that best practice as well, not just looking at actually does it meet the minimum criteria. Second section, professional assurance, and arguably one of the most important. So this section starts with risk profiling a technology. What's the level of clinical risk if a patient decided to go on, download and engage with the technology on their own without it being recommended by a clinician or coming from a trusted source? Using an enhanced version of the NICE Evidence Standards framework, we will classify what features, functionality, a product is delivering, what's the intended outcome on the patient, and ultimately what level of clinical risk does that correspond to. So NICE, because they're a lovely straightforward organisation, have either tiers A to C or 1 to 3B, depending on which version you look at. We have levels 1 to 4 that directly correspond, each one with its own set of requirements in terms of the evidence we need to see. A level 1 product being at the extreme end something like the equivalent of an electronic leaflet, for example, where it's giving very generic advice and guidance. It's not patient specific, it's not even necessarily condition specific in some cases, but it's a resource that patients can access. All the way through to level 4, which typically, again, at the extreme end, think AI chatbots delivering CBT therapy, for example, seems to be a rise of those in the anxiety support space. Obviously, if it's delivering unsupervised therapy, that level of clinical risk is exponentially higher. So the level of evidence we need to see in order for that to be deemed safe is proportionate to that. The last section, usability and accessibility. So for native mobile apps, looking at the iOS and Android store guidelines around what makes a good usable quality product. Also looking at the web content accessibility guidelines, some of the recognized standards as well, but then going into some of those accessibility features. So things like, how does a product fare if somebody's got a visual or a hearing impairment? Does a product have text to speech or adaptive font sizes where it's relevant to enable that, ultimately to enable that user to engage with the product? Oh, I can see Kevin's dropped a question in. I'll pick all questions. Or Kevin, did you say you've got you've got to drop off actually. Let me pick that up.
I'm going to leave at 10:30 for a meeting, but I'll be coming back.
Okay, what we'll do, I'll pick all questions. I'll pick all questions up at the end of the bit, if that's all right. Just in case I happen to cover it off. So that ultimately the outcome of going through. The outcome of going through the baseline review assessment is that ORCHA Assured badge. It's actually, we don't say our app's great. ORCHA have assessed it against all these criteria, and ORCHA say, yep, this has met the minimum standards. Recently, so I don't know if any of you joined our webinar session that Liz and I did back in October, and we relaunched the ORCHA Assured process completely. We've completely redefined it, including a new silver and ultimately gold tier of compliance. So bronze means you've met the minimum global standards. You've demonstrated evidence in all of those areas. When we move on to silver, we're talking, apologies, this slide's a bit tricky to read because silver with white lettering doesn't work very well. But the important thing is what we did when we were developing the silver assessment is take all of those baseline review criteria, take all of the criteria that we know are being asked for around the world, and this table demonstrates that quite nicely, to say, okay, what questions are being asked consistently across all of the other markets that we're supporting. And as you can see from the ticks on the board, the consistent trends were around clinical safety, technical stability, and technical security. So with the silver assessment, ultimately what we worked to do was to bring those criteria out. Apologies, my throat's gone a bit funny. Worked to bring those criteria out into a set of questions that means if you can pass the silver assessment, actually you're teed up for even more markets than, and that step closer to readiness in terms of engaging with the US, organisations across the EU, teeing up for the NHS DTAC, etc., etc. As part of those clinical safety requirements for silver, what we start to look at is some of the DTAC principles around clinical risk management, clinical risk processes, and continue evidence of continuous risk monitoring. So as part of that assessment, you provide evidence of those. We work through the documentation, validate it. Technical stability, ultimately we're looking for evidence of things like load testing, but also going into evidence of an active penetration test. So when I get into DTAC, that will clarify a little bit more, but as part of the NHS DTAC, you're required to have a penetration test that's been done in the last 12 months. So we've brought that in as a uniform standard for silver. As well as evidence of an external cybersecurity accreditation, so something like Cyber Essentials as an example, where again it aligns with best practice across not only the NHS but actually across the UK market as a whole. Let me just come, because I can see questions coming in. So I'm going to answer I'm going to go for your second question first, Kevin. So in terms of the yellow card system for drugs, so NICE have obviously a yellow card system around medical devices, which is applicable to software as a medical device and more traditional medical device as well. There isn't a formal central governing body for digital health technologies in the UK in the same way as, say NICE or the MHRA work for medicines or medical devices. So there isn't a formal reporting process for that. I guess we've kind of assumed a little bit of that role, and as part of the review, poor software design, I would say, is a slightly too subjective criteria for us to look at as ORCHA. But what as part of all of the, for example, if we look, looking back at the silver criteria, if a product can't demonstrate penetration testing, it can't demonstrate things like clinical efficacy, then actually as a health technology, we would classify that as a poorly designed technology. I absolutely agree that the current DCB documentation for DTAC does not handle those issues really at all. And I had a really, really interesting conversation. I don't know, I'm sure lots of you are aware there's a review process ongoing for the DCB documentation and the DCB processes at the moment with NHS England, along with a revised version of what will become DTAC version 2. DTAC version 2 will be announced by the centre at some point in the next 3 or 4 weeks. That will go live. But I'd had a meeting with the department last week, and they told me that the clinical safety, the DCB updates will not be launched as part of that because they're not ready. So I'm not 100% sure what DTAC version 2 is going to look like without the updated clinical safety section. But that's that's a really fascinating thing that they've been working on that now for 3 or 4 months to my knowledge, or certainly public knowledge, and they're still not at a point where they've got a consensus on what the new NHS clinical safety standards are going to look like. Kind of segueing into that is, I'm sure lots of you have heard it, or read in the 10-year plan, or heard a bit of a buzz around the potential innovator passport, to allow you guys as innovators to be assessed by one NHS organisation and passport that compliance across to another trust, another ICB. There's been a huge amount of noise, and I've had, as you can imagine, a lot of questions asking, well, does that impact ORCHA? That has been a really interesting conversation with the team at NHS England. So the current options that are being considered, or that have been submitted for consideration by the team that are working on it, include the innovator passport being nothing more than central published guidance, in the same way that DTAC is currently central published guidance, all the way through to potentially a central managed assurance process. The feedback that I've had from the National Clinical Safety Officer Network is that unless it is the most extreme example of that, there is no way every trusts are going to accept the if I use my local area as an example, if I go to Northampton General Hospital and say, yeah, you've been through DTAC with me, you've validated it. If I go up to Kettering General Hospital, they are not going to accept Northampton have validated it, so we're just going to implement it. The clinical safety officers have been very clear that they are not going to accept that as a single point of sign off. So there's a lot of shifting around the DCB documentation, but I absolutely agree there are so many flaws in it that that's it. I'm very intrigued to see what changes they come out with. Does that help? I appreciate it's a long-winded answer with lots of anecdotal answers.
Well, yeah, I mean, I used to be a clinical safety officer, so I'm very familiar with the 129160 process. I think that the main thing I was going to say about the design of software is, for example, when I use my EPR, if I okay a patient's result, and as it goes off the screen, I suddenly realize it says there's a new liver cancer visible. As it goes off the screen, I can't go back and find out what that patient was. So there are some things that are inherently dangerous about some of the software that we use, and it's not so much just not well designed. I mean, some things are just bad, very badly designed. And I think when any software, if it causes patient harm, there should be a simple way of reporting it, like the yellow card. If you have a drug that causes you to develop multi-organ failure and die, which is what the meeting is I'm going to next in 5 minutes time is about, then you can report it. But if you have a software issue that's really bad, that kills a patient, you don't have an easy way of reporting it other than a DATIX.
No, and I think the only exception to that is if the product is a registered medical device with MHRA.
Obviously, issue, but that many of the EPR systems are not registered devices. Yeah. Interestingly,
No, absolutely, and I think that's where and I'm sure you've read lots of the very interesting conversations around the classification of things like ambient voice technologies as medical devices, and lots of people arguing that they're essentially like an EHR, they're like the health record in as much as they're an administrative tool. They're not a medical device, and then actually it's pretty much generally the clinical safety officers and others in the assurance space saying, hang on a minute, the potential for this to have a direct and indeed detrimental impact on a patient's outcome is huge, because it's providing summaries, it ultimately could lead to things like curved thinking, and if they then go down the route of diagnostics, that kind of thing, that absolutely they should be a medical device. And again, I feel like this is going to come across like I'm spending the morning slating the centre here, but I don't. Obviously, in the ambient voice technology space, the solution from the centre is to have the National AVT Register, which is hypothetically a great idea until you actually read into the requirements for that, and the fact that it only requires class 1 medical device, which is self-registered. So the value of that, I'll leave you to your imagination. And it requires self-attested DTAC compliance. So again, it's back to that, you're asking the technologies that are ultimately trying to profit and scale in the NHS to say, yep, we're safe, yep, we're compliant, and we say so. And certainly the mandate of that registry is they're just going to trust that, which, as we know from DTAC experience, doesn't work. DTAC has been a self-assessment for 4.5 years, and something like of the DTACs that we've assessed, whether it's on behalf of the NHS, whether it's because we're working directly with the provider, 90% of them have failed, and in many cases they have been to consultants to have the work done, and actually they're not up to standard, they're not meeting it, yet they're DTAC compliant in as much as they've done the work, they've got the documentation with all the right names on it, and they can submit that and say, yep, we've decided we're DTAC compliant. So again, it's the AVT registry is another attempt at solving a problem and be seen to be doing something without actually solving the compliance problem and actually solving the challenge that the providers on the ground are struggling with. But I mean, and Kevin, if you're happy to have a one-to-one afterwards and put the world to rights on this more, if you'd be up for it, because we're having lots of
no, let's do that.
Let's do that bit. But ultimately, on both. So back to the slides. Now I've put the world to rights. The outcome of both of those assessments ultimately is that ORCHA assured crest. It's that trusted badge to say, we don't say our product's great, we're not claiming this. Actually, it's been independently validated as clinically safe, data secure, usable, etc. And only a product that is maintaining that. So, obviously Shane said earlier, they're already on their ORCHA assured subscription and we're working on that. Only a product that is actively maintaining that assured status receives the badge at all in the first instance. So you can see we've now got an expiry date on the badge to ensure that products can't just claim it in perpetuity. They're trying to explain to technologies that if an assessment was done 3 years ago, that assessment is no longer in date. However many updates you've released in that period of time means we can no longer independently say we've assured that technology. It's kind of that simple. And I always like to credentialize a little bit, and some of the companies that we currently work with and that are part of the ORCHA ecosystem, spanning one-man band technologies that you've probably never heard of, the likes of DadPad, which is an amazing product based down in Cornwall for new fathers, all the way through to the multinational medtechs that we're supporting in some cases with looking at the UK market for their digital technologies, supporting them with DTAC compliance, looking at different global markets, or that just want to be ultimately just want to be in the ecosystem, so they've got that visibility. But ultimately, and this is a slight duplication, but it's about being that partner for international standards and international growth. What we can do within the ORCHA ecosystem is we can, where we talk about the fact that the US standards include the criteria from the baseline review, internally we can passport that compliance across within the system to say, you've been through the global baseline review, you've scored this is the answer to that question set. Actually, those questions also feature in the US standard, they feature in DTAC, which makes it really, really quick and easy for us to say which standards you're either working on, working towards, or actually you're compliant in ultimately these markets. How that is then surfaced, and the second part is going to focus a lot more on what that means from a distribution sort of angle, but one that I always like to put up, and by all means scan the QR code and do go and have a look for either other technologies that you're aware of, or potentially your technologies as well, is the new ORCHA Verify service. So a bit of background to this. Obviously, off the back of our work with the NHS, we get somewhere in the region of a couple of hundred inquiries a month asking us, is a particular product ORCHA assured? Has it been assessed? Is it compliant? Any version of that request, in different guises from different organisations. And one of the things we were really keen to do, partly because we know there are a number of companies out there that are falsely claiming to have an ORCHA assured status when in fact they don't, is to launch a tool that allows people to go and check that status. So if somebody is claiming to be ORCHA assured, actually you can go search for their product and you can find it in the Verify tool. Launched just a month ago, and a month ago, 4 days ago, and what's been really interesting is it's very quickly become the most visited page on our website, with hundreds of requests going through it in the first 2 weeks alone. Sure, lots of those were people going and checking their own apps, but marketing likes statistics like that. What Verify shows ultimately is what the product's current status is. So is it ORCHA assured? Has it been assessed previously, or is it not in the system? It'll show the level of assurance we've given that product. So has it got bronze? Has it got silver? Future, it will show gold when that comes out in the next few months. And then it gives you the ability to either request the compliance report on a particular product, or go through and actually allows a user to subscribe to ORCHA Compare, which again I'm going to do a demo of, which will then allow them to search the entire ecosystem of, it's 2,400 on there. It's nearly 2,500 products now that are featured in that repository. I'm actually going to pause there and take a breath and just ask any questions at that point. Obviously, I know Kevin's had a few, so I'm just going to take a breath there because I'm aware it's a lot of information in not a lot of time. Perfect. Let me just jump across. So then we start looking at things like the NHS DTAC as one of those enhanced assessment frameworks that we've obviously supported since its inception 4.5 years ago, whatever it was. Now, the way we work with DTAC is very much a journey as opposed to a one-off assessment or a one-off process. So the first step whenever we're working with a company on DTAC, and particularly where we're working with global organisations that are looking to enter the UK as a market, is actually to look at what we call DTAC readiness, is to look at that gap analysis of where you are currently at on your compliance journey, and then what that means in terms of DTAC standards. So across the 5 domains, which areas are you going to have gaps? Which areas do you need to focus on? Far beyond the typical gap analysis that I've seen from a number of DTAC service providers like clinical safety organisations, etc., where they go through and ask, do you have a clinical safety officer? Do you have a DPO? Do you have etc., etc.? When we're working on DTAC readiness, we start with that baseline review assessment because it gives us so much detail and so much insight into the way a technology works, who its intended audience is, what its intended outcomes are, where it fits within the health system as well. Is it going to be plugged into the health record? All these kinds of things, which allows us to produce the most comprehensive gap analysis available. Not just looking at, do you have such and such criteria, have you done it already, but actually which bits do you need to do in order to be able to demonstrate compliance. Equally importantly, in many cases, which bits might you not need to do, or which requirements might be reduced ultimately, because you're not plugging into the health record, or you're not reading and writing, you're collecting a lower level of patient data, etc. I had a slightly shocking conversation with a supplier a few months ago, where were working with a number of consultants, a reasonably large organisation, and they'd gone out and sourced an interoperability consultant who spent 2 months with them. £15,000 or so they spent with this consultant, working through all of their documentation, working through their product, all this kind of stuff, only to get to the end of it and tell them, actually, you're not ever right. You're not interacting with any patient data. You're not working with NHS APIs. you don't need to look at interoperability in anywhere near the same way as you would, as you could do. And my response to that was, well, you'd have got that off the back of that initial ORCHA assessment. As a little bit of background to DTAC, so replacing the DAC as it was 5+ years ago, and the key thing with DTAC is that it's the responsibility of every individual. Well, I'll caveat this with, we'll see what the changes say, but it is the responsibility of every single NHS provider that's commissioning a technology to go through this process and make sure their estate is compliant. Don't know if many of you will probably have seen the research that Dr. Keith Grimes and co did a couple of weeks ago, where that something like 2/3 of technologies in current use in the NHS haven't had the appropriate clinical safety sign-offs. That tells you an awful lot about how the NHS has engaged with DTAC over the last 4 years. And I'm always really transparent. The biggest challenge for you guys as digital health companies is that every NHS provider will work with DTAC in a different way. They will often have a different process, typically amounting to asking you the same questions, but ultimately in a different way. I'm convinced in some cases it keeps chief information officers in a job to ask awkward questions about DTAC submissions with some of the questions I've seen come back. But again, as ORCHA, what we will do in relation to DTAC is validate each of those domains. So post baseline review, post that readiness, that gap analysis piece, we'll then say, this is the documentation you need to submit to us in order to have that DTAC validated. Each domain then goes off to one of our subject matter experts for independent review. They will work through that essentially line by line. They will mark every document. They will work their way through it, and they will produce a report on their section to say, yeah, your hazard log, your DPIA, your etc. meets the criteria as set out by NHSE, and that will then be compiled into a report of either compliance that can be circulated across the NHS, across any provider ultimately that you're looking to work with, or they'll say, actually, you haven't met the standards. This is perhaps where there's a problem, or where something hasn't been done quite right. Again, I'm always overly transparent and say DTAC is a self-assessment. There is not a requirement in some geographies to have it independently assured. We are starting to see more and more NHS providers, particularly at ICB levels, starting to ask to have it independently assessed. And in some cases it comes to us. There are other DTAC service providers as well that do a similar thing. And there's kind of 3 ways that a provider or an NHS organisation will use an independent DTAC report. The first group, and arguably the best group from your guys' perspective, will look at an independent report. They'll say, yeah, it's from a trusted source, it's from ORCHA, etc. We know, we've worked with them, we know that's going to be fine. All we need to do is the DCB 0160, which obviously is their side of the DTAC. There's a group in the middle that will look at the report, say, yeah, that's great, but we want you to submit everything across to us and we will go through our process. Or they'll come back with awkward questions or those kinds of things. And then there is a third group, fortunately getting ever smaller, but there is a third group that ultimately will have their own unique process. In some cases it will include parts of DTAC, in some cases it will include weird and wonderfuls, I'll be completely honest, but typically amounting to the same key areas where, and if any of you that have sold to the NHS will have experienced some of these joys as you go from one trust to another, which I think is why there's such a potential excitement about what things like the Innovative Passport ultimately could become. I'm just going to skip through that because I've kind of talked through bits of that already. Talk through a little bit about how the NHS currently assesses DTAC. So you will go, essentially as a supplier, you will go away, complete the question set independently, and that will then get submitted to the individual organisation, be that an ICB, a trust, PCNs are a slight nuance. Some seem to ask for it, some seem to ask for it in bits. They will then go through and they will assess. They will appraise all of that documentation. It will go through clinical safety, IG, all those kinds of things. And then if they pass, it then becomes back to your responsibility as a supplier to update them, update the documentation, any changes, that kind of thing, in line with your product updates, any changes to clinical risk, hazards, all those sorts of things feed into that. And then as has happened over the last few months, there are then audits for DTAC compliance across digital estates, although NHSE hasn't done one for quite a while, which I think is why Keith and colleagues produced the report that they did. The way, and I've kind of touched on lots of this already, so the way that we conduct that enhanced assessment, and obviously DTAC in this case, but whether any of the frameworks that we support around the world, always starting with that baseline review, because it gives us that detailed level of understanding of what the product does, who it's designed to be used for, what the clinical condition areas it can support are, what the potential risks are, all those kinds of things. You'll then receive that readiness report for whichever enhanced scheme you're ultimately working towards. That then goes back to the assessment team to say, this is the documentation that we think we need. That gets signed off, comes back to you. The team go away, conduct that initial review, gather that initial feedback. We will then go through, pass or fail, but then it goes into that maintenance triage again. So like with the baseline review, that continuous monitoring, with something like DTAC, obviously a number of the elements of the documentation, whether it's penetration testing, whether it's cyber essentials, whether it's ISO standards, etc., are annual certificates. They need to be updated, they need to be maintained outside of the DTAC process. So we will essentially conduct a reassessment, typically once a quarter, on something like DTAC, to make sure that we've got foresight of any changes that are coming, any changes that have happened to the product as well. And obviously, if as part of that process we identify a significant new feature, a significant new change, then actually what we will do is work through and say, right, this is how that impacts your compliance with those standards. And I must have rattled through quite quickly because we're at the first Q&A already. I must have been talking too quickly. So I'll open back up to any questions, thoughts from anybody.
Yes, I have a question. I have seen that this is about digital technology. I think that is more about, I don't know, apps that use any point of care or like tracking heart conditions, etc. Do you do this for in vitro, or have you done this for in vitro diagnostics that have digital, well, that uses or may not use anonymized patient data or something like that? Have you done this before?
So historically, if you'd have asked me that question probably 2.5 years ago, we were as ORCHA, we were very, very focused on patient-facing health apps and technologies. So essentially, is the cliched examples of Headspace, Wiser, Sleepio, those kinds of solutions where they were a mobile app that was designed very specifically to support a patient. Over the last couple of years, that scope has really, really broadened. So we've been asked to assess everything from essentially anything digital and software based within a healthcare setting, ranging from virtual wards, HR and appointment booking systems, clinical reference tools, clinical calculators, those kinds of technologies where they're not, in many cases, ever going to be seen by a patient. They're not designed to have a clinical outcome. And actually, that's where the flexibility within the review process works really well, because if they're essentially not providing a clinical outcome, then you don't need to provide clinical evidence, right? So the review process has very naturally adapted to actually anything with a software angle we can support with the assessment of. as a kind of idea of the breadth of some of the conversations I've had in the last week. Yesterday I was speaking to an ADHD diagnostics and triage tool. The day before that it was a data aggregation tool that was out in the US that ultimately supported health systems with data analytics, and everything in between. So anything with a software side we can support, particularly with DTAC. I think I'm always, again, really, really transparent that the baseline review for products like that can be a little bit challenging. And in some cases, it can be a little bit more back and forth. It's not quite as smooth a process because obviously it's a slightly different type of technology. We can't just download it from the App Store and use it in the way that a patient would. But particularly for things like DTAC, it's such an involved process anyway that the type of technology kind of doesn't matter as long as it's software based.
Okay. And probably I'll follow up. That includes because the new rules about AI as a software medical device, whatever definition they are making it.
Yeah.
That also applies to that, or for example, restoring the predictions of a certain patient that uses certain patient data, if it's anonymous or not. That also includes AI applications.
So I think I imagine there'll be an interesting grey area if it's using completely anonymized patient, i.e. ultimately that if it's using completely anonymized patient data, then the intended outcome isn't that it's a specific patient's treatment. So at that point, I imagine there'll be a slight grey area in, well, if it's pulling together lots of data and essentially, it is analyzing, aggregating it, that's very different to an AI tool that's being used as part of a one-to-one interaction, or, going back to the ambient voice technologies example, that's being used in a clinical setting and ultimately, in the case of AVTs, summarizing appointments, putting the appointment notes in, all that kind of stuff. The honest answer with anything that isn't the honest answer with anything that's AI in NHS at the moment is they don't know. So one of the things that we're working on that again will go live we're hoping this side of Christmas, is an AI specific assessment module for health technologies. So it will apply to everything that is using AI in a healthcare setting, whether it's a patient interaction tool, whether it's clinical, wherever it fits in the system. But obviously looking at some of the more fundamental principles of using AI in healthcare, like how are you alleviating model drift? How are you looking at things like guardrailing? An example of that I had quite recently was a really quite clever and quite interesting MSK technology, that they'd done a study somewhere in Europe with a cohort of patients that were on an MSK pathway. And one of the things they then decided to do was to embed an AI chatbot so that patients that were on the app could ask advice, could ask questions. But as anybody that's ever looked at or tried to develop their own LLM knows, that's a very, very expensive and very, very expensive and very, very long process. So they had plugged ChatGPT in as a kind of middle ground, as a middle ground. And so having to explain to them that actually that in itself creates an exponential risk, because they were doing, it was actually quite cool because they were sharing their phone in Teams, which I didn't know you could do, and they were showing me it, and it was really, really cool. So I said, let me take over. So I took control and asked their chatbot a question about managing anxiety, which obviously is completely out of scope of an MSK specific solution. Their study that they'd done is very specific to MSK. And obviously, because at that point, ChatGPT hadn't announced that they were going to stop people asking medical questions, it gave me a lovely answer about managing anxiety, and having to explain that actually that, although might be useful, you're not validated in that clinical setting. Therefore, your product can't be giving advice on anxiety. You can't just plug ChatGPT in because it will give you an answer. It's designed to positive reinforcement, isn't it? That's how it's coded. So it will give you an answer to anything you ask it, that's not okay in a healthcare setting, because
Yeah.
if somebody's coming to your tool for advice on something specific, it needs to be locked down to something very specific. So how you kind of alleviate things like that as well. And when the AI module goes live, it's been a 12-month project, I think, developing it. It's already a couple of hundred questions just for the AI module on its own. And it's the full breadth of how can it be used, questions that you can ask it, how is it safeguarded, what information sources is it pulling from, all these kinds of things. But when you talk to NHS providers about this, I've had this conversation with a number of people, and you get a jaw drop moment, because it's things they haven't even thought about. Particularly at like local trust level, they haven't actually thought about the wider assurance piece around their AI technologies. So yeah, the short answer, the long way around the houses, is the centre and the NHS more broadly don't know what they're going to do properly with AI yet.
All right. Thank you.
You're very welcome.
Jordan, should we break now for a comfort
Yeah,
break?
I was gonna. There we go. There's my next slide. Here's what I made earlier. And obviously, if anybody, obviously I'm here. So if anybody's got questions or things, but more than happy to do. Yeah, let's do a 5 or 10 minute. I don't know how long you normally do.
Well, should we say till 11 o'clock?
Yeah, works for me.
Yeah. Okay. So if you want to come back for 11, everybody, that'd be great. Jordan, should we start off?
Absolutely. So obviously talked an awful lot about assurance, and hopefully this is now the more exciting bit that people won't want to fall asleep through. So obviously ORCHA assurance is only one part of a very, very big ecosystem, although it's the part that ironically we're best known for around the world. Actually, it's one small component of all of the projects that we're running. So, and I'm going to demo lots of these platforms. It's going to be a little bit more interactive, hopefully. But ultimately, although assurance is that first step, that then brings you into the ORCHA Trust platform. So allowing market insight, obviously I touched a little bit on Verify, the public facing platform to allow people to check a product status, and ORCHA Compare, the detailed deep dive version that allows a commissioner, clinical safety officer, anybody within the health system ultimately that's responsible for identifying, selecting, or conducting due diligence around a technology. Compare gives them that insight. But then into actually what does that mean for market access and actually getting patients engaged with digital. So the first platform is ORCHA CareNav. So brand new, launched June, July this year, very specifically aimed at primary care and designed to take patients on a journey to identify a tool that can support them managing a long-term condition, their mental health, their broader well-being, or something more specific and specialized like neurodiversity, that kind of thing. The second platform and solution is called CareQ. So this is specifically designed for elective care, waiting list management, and allows us to deliver automated text messaging, essentially automated e-prescribing of digital health solutions directly to a patient based on the pathway they're on, their specialty codes that have been identified within their health record, and aligned with communications that are already going out as part of things like waiting list validation, where actually we can then offer something digital to support that patient either be ready for their procedure or to support them post-op as well. The public-facing libraries are a slightly broader version of CareNav, so these will typically include a far broader range of technologies. So typically this is the kind of solution that an ICB will work with and allow them to push that out across their patient groups, either very, very targeted, so they do campaigns running to a specific collection of apps that are designed for a specific cohort, or actually as part of a broader population health angle. The digital health formularies, allowing healthcare professionals to go in and actually e-prescribe a digital technology on a one-to-one basis, and then a whole range of partner schemes around the world where they are publicly, they won't look like an ORCHA site at all, but that actually they are underpinned by that ORCHA assurance, and all of which is ultimately designed to support either a patient population or a professional population. So organisations like Pharmacy2You, notably in the mental health space at the bottom four. So we support Mind UK nationally. They have a central library of assured digital mental health solutions that ultimately are branded as Mind approved. Ultimately what that means is they've been through the ORCHA governance process and then been through some enhanced Mind assessment criteria as well, and that's exactly the same with the Mental Health Commission of Canada nationally. And then recently we've gone live with the American Psychological Association as well. So across the US, typically we work with the member associations as opposed to working with the health systems as we do across the UK. And it's about giving those professionals access to a list of approved digital technologies that are very relevant to their specialty or their clinical area. So obviously the American Psychological Association, very mental health focused, also supporting the American Physical Therapy Association. I always get the acronyms all wrong. Obviously, again, primarily looking at MSK type solutions, but also including some broader well-being technologies as well, and then a whole range of others. And I'm actually going to jump into the demos slightly earlier than I'd planned, so I'm going to stop presenting and share my screen instead. Hopefully that's come up. I can still see you guys. Is that somebody do a thumb? Yeah, perfect. Thanks, Indy. So ORCHA Verified that I touched on earlier, I'll very quickly show, and I'll send you all out the link to it as well, so you can go and have a look. But very specific purpose, designed to check the status of a specific product. So if we were to look at a name like Headspace, which we all know and love, we can see they're ORCHA assured. We can see when that assurance is valid until, and we can go into a little bit more detail about what that means, what compliance they've demonstrated. What it also allows is you can add that to a watch list. So if I'm a clinician and I'm in this case in a mental health setting, and actually I'm recommending Headspace on a one-to-one basis, actually through their professional account with ORCHA, they won't necessarily be notified if a product's compliance status changes because they're using it as a search tool. This allows them to go in and say, actually, I know I'm recommending Headspace 3 or 4 times a day. If something changes with that product, I really need to know about it. So they can add that and be notified if there is a lapse or a change in its assured status. We can go and access the compliance report. Again, because it's built on the baseline review, the compliance report will only feature publicly available information. So that initial assessment is all done using publicly available information, and that's all that will ever be surfaced in a public environment. Or if it's part of our role and we need to look at lots and lots of products, we can subscribe and we can go and look at the ORCHA Compare platform. I'll do Compare next. So this is what powers the Verify service. So the world's largest repository of digital health technologies, something like 2,500 products that are featured, and actually for the first time, back to kind of Carlos's question, gives us the first place where we can really push products that aren't necessarily designed for a patient. So with those categories around professional solutions, looking at the kind of examples I've given earlier around clinical calculators, diagnostics, those kinds of things, or administrative tools where actually they're not actually ever going to be purchased or bought by a patient, but as a system it's really important for them to know their compliance status. If I was looking for a technology, and I always use anxiety because it's the area I'm most familiar with, we can see there's 230 products within the ORCHA ecosystem that have actually been identified as supporting a patient with anxiety. what as a commissioner I can then do is I can then say, right, well, I've got a specific use case that I'm looking to meet. So I want something that's completely free. I want something that's available on iPhone. Let's go for, I want something that's offering CBT support. What we can then see is in that cat, so based on those filters, we're down to 7 products that are actually relevant, and then we can see the score outcomes. So say for a product to be passed and to be ORCHA assured, it needs to score 65% as an average. So we can see 4 products out of the 7 actually haven't met those minimum standards, and then we've got 3 potential technologies that actually meet our criteria. What we could then say is I need something that's suitable for, let's try, let's just go for adults, why not? If we add an adult filter on, actually only one of those technologies has been designed to support adults manage their anxiety, that's available on iPhone and is entirely free. So we can then go in and learn a little bit more about Thrive as a technology. We can see from the description, what does it do? What type of services is it offering? We can go into things like pricing, all those kinds of things. And then the further we go down, the more we start to get into some of that compliance information. So we can see it's been through the global baseline review. The DAF is the US Digital Health Assessment Framework. So we can see it's validated against that as well. And we can see some of the more detailed compliance outcomes. If a product has been through DTAC with us, that looks quite substantially different. So I know the guys at Sorted very well, so we'll use those as an example. We can see they've got that silver assured status. They're on that higher level of compliance, but they're also going through DTAC with us. And then part of the reason I use them is because they're also part of the MIND project and the Mental Health Commission of Canada. So we can see they're validated there as well. But then when we go into the actual detail around what compliance information we hold, you can see the level of information there is considerably higher. So we've still got the three baseline review, the 3 baseline review criteria sets, but then actually we've got all of the DTAC criteria sets here as well. So if we drop into clinical safety, we can see, we can go through that line by line as a commissioner, as a clinical safety officer. We can see where perhaps it has met the standard. In the case of this product, actually their documentation's not far off perfect, or actually if there were areas in there where things were needed improving, obviously we'd have advised you as a developer of that, but we'd be able to flag in here that actually they don't have an up-to-date hazard log, or they don't have an up-to-date clinical safety case, these kinds of things. And same for all of the areas. As a commissioner, I can see, without needing to go back and forth with you guys as a supplier, I can see all the insights into the various areas of DTAC that I'm going to be interested in. We can see where it fits under interoperability criteria, and then we can see the outcome of the technical security section as well. So when was the penetration test done? Has it been done by an approved body? All these sorts of things that come into that as well. So really giving them that detailed, that kind of detailed analysis to say, yeah, this is going to tick all our boxes, meets all the criteria, all that kind of thing. From a patient-facing perspective, so the first platform that I talked about was CareNav, and again, designed very, very specifically to allow the patient to go on a journey. So we're not presenting the patient with a search bar to go and search through thousands of products or to go through filter criteria or anything like that. What we're taking them on is, what health area are you actually looking for support with? So if we drop into long-term conditions as an example, we can then look at six key long-term condition areas that have been mapped out as part of our work with the primary care networks. If we then look at diabetes, what type of support as a patient are we looking for to manage our diabetes? Am I looking to adopt a more digital blood glucose monitor? Is it advice and guidance, medication management, or is it something as simple as managing my diet and eating well? Again, we go in, and rather than like in the compare site, for example, where you would be met with in the first filter, the first time you see apps, there's 230 of them. In this instance, actually, we've got 5 products at the most that are identified in that top section as being very relevant to this patient group, relevant to managing diabetes, supporting with eating well, and that will be providing slightly different features and functionality depending on what the patient's looking for. So if we drop into, we can either go and download as a patient, if obviously on a laptop we get the QR codes to go to the respective app stores. If I was on a mobile device, obviously it would just take me straight there. Or again, we can go in and we can learn a little bit more about this technology. What's it designed to support? How does it work? What kind of functionality is it going to give me? And then if we're interested, again, we can still see that overview of the compliance information. And where are we? Apologies, just need to jump back to this one. Where I then talk about the broader libraries, NHS Dorset is a really great example. We've worked with their ICB for 5 or 6 years now, and ultimately it's about they're an ICB, so there isn't a specific set of condition areas or focus areas. They want to feature all the digital technologies that are assured, that have met, and they've put some criteria in around they don't want ultra high risk, so things like the level 4 on the clinical risk technologies. So we can say they've got something like 950 last time I checked technologies that feature in their library. And again, very, very familiar in terms of that search functionality, as you saw within the Compare platform. Only this time it's with the patient. To go through and search. The other channel that patients will be directed to is to one of these specific curated folders of products. So in the case of things like children's health, maternity, etc., we've done a huge amount of work with the Family Hub in Dorset. It's obviously really critical areas for them, and they've done a huge amount of work in the children and young people's mental health space. So one of the areas that we see the most visibility and the most traction being generated, giving a bit of an overview of why the technologies have been selected, why it's so important, why they can support those patients, and then a range of, again, different technologies. Lots of the STEM 4 technologies are featured in here because Dorset have a really good relationship with them, and then some other products as well that actually have been identified as relevant to supporting that group. Dorset have pushed this out in a whole range of different ways, spanning from text batching across parent populations via the Family Hub, QR codes in surgeries, social media. They've done a huge amount of work to actually drive people to this as part, ultimately as part of their care. The flip side of that, and the professional side that I'd kind of described already, is the digital health formulary. So very much designed for clinicians to use to go in, either identify a technology or to then go on to e-prescribe that to their patient. So if we were, again, doing a search for anxiety, if I could spell it properly, that would be great. We can see, again, we've got a huge range of products in here. Within the formulary, the clinician will only see something that has passed and been validated, has scored over that 65%. If they then want to, and I won't go through the full searches again because you've seen that, but we've then found a technology that we want to prescribe to our patient. We can do a direct recommendation either from within the electronic health record. So if we integrate with EMIS, System 1, Epic, Cerner, Vision, a couple of others, to allow them to essentially do it in as little as 3 or 4 clicks. So all that information would auto-populate. Once let me just put mine in. Once we've sent a recommendation, we can then go in and see the full recommendation history. I can show you because this is obviously my demo account. So we can then see what product has been recommended, what date it's been recommended, and we can see has the patient gone on to download it. If they haven't, we can resend that recommendation to them to give them a nudge. What that also gives us is a full audit trail as well. So where I talked about that continuous monitoring piece, if we were to identify a problem with the technology that's being recommended to patients directly, actually what we have the ability to do is essentially to recall that and say, actually, here's an alternative technology that you might want to recommend instead. Fortunately, it doesn't tend to happen too much nowadays. Products don't tend to fluctuate in the way that they used to, and we don't see anywhere near as many drop off as we did a few years ago. But there was a period of time where products would no longer be available, or there was a case, I think last year, where a product pulled out of the UK market, so it wasn't being made available to UK patients anymore. And so again, we're able to go in and say, this is where that's featured. We can then replace that. We can replace that with an alternative. Again, I'm going to pause for questions while I come back to my slides as the distribution side of ORCHA, and then I'll bring my slide deck back up. Not many questions today.
Sure, Jordan.
Yeah.
I have a question. Upon an initial ORCHA review, if there are lots of areas to work on, do you hold off publishing the final score until those areas have been resolved, or do you initially publish where the product is at and then work on them in the background?
So it can be either or, to be honest. If the review is requested by, so obviously as part of working with all of our NHS partners, they can request assessments. If they request the assessment, then obviously they will get access to it, albeit after you guys do as an innovator. So you guys will always get sight of the report first. Nothing will ever go public in as much as patient facing until it's scored over 65%. So if there's a long list of, in some cases the initial assessment fails simply because not all the documentation is in the public domain. In lots of cases, clinical, things like clinical safety, public evidence of efficacy, data policies, lots of that often isn't in the public domain. So the initial assessment will fail simply because we can't find something. So it's a constant back and forth process. But typically it will feature in compare if it fails. So kind of regardless what the score is, it will flow into compare anyway. But you absolutely have the option to not publish that, and that's a conversation. It's not published by default, if you see what I mean.
Understood. Thank you. Yeah, no, I'd be interested to have a meeting with you soon, as we assess sort of moving from, let's face it, a sort of a consumer light touch health and fitness app into something more clinically robust as we sort of move forward. But obviously, I appreciate it's quite a long journey. But anyway, we can take that offline.
No, absolutely. And I always say with all of our support subscriptions, whether it's whatever level of assurance we're working on, it isn't like going through an ISO audit. It is not a case of, oh, you're paying us for X number of hours or X number of assessments or this type of support. Once you're part of the ORCHA ecosystem, we want to help as much as we can. We don't track. If you have, you can imagine working with companies like Headspace, Calm. I'd imagine Sweatcoin is another example where there's probably updates and new versions released weekly in some instances, bugs, bug fixes, patch fixes, those kinds of things. So with practically speaking, putting a restriction on number of reassessments, those kinds of things has always been difficult. But once you're part of it, it's about supporting you towards whatever whether it's the NHS, whether it's the US, whatever markets you're looking to engage. It's about that continuous support. So if you say, actually, we don't want to publish anything until we've scored, I had one a month or so ago, we don't want to publish anything until we've hit 80%, or 90, or until we've achieved silver, or that's a very normal request, because obviously people want to be published in the best possible light. They want it to be seen that actually they're as strong as possible. So no, that's absolutely something we're very used to as a request.
No, thank you. And in terms of once you have a scoring, and at those different levels, do you have any test cases or cases of the difference it's made to an organisation in terms of inquiries into ORCHA from an organisation that wants to sort of, I suppose, verify or check up on a company, or a sort of a test case of before they were in ORCHA and post they're in ORCHA in terms of winning business?
So for complete transparency, it's something we're just starting to track. I think one of the things that obviously we're starting to do now, particularly with things like Verify, is we can track the search terms. We can see if a particular product is being searched for. The next evolution of that, particularly now we've given the Compare platform away for free to the NHS, is that obviously we can see which organisations have signed up for a Compare account. We can see what their search terms are. So what we're now working on is essentially an environment for you guys to log into and be able to see, oh, Manchester University Hospital have searched 6 times for us, or so we can start to feedback some of that really direct, oh, these guys are interested, pseudo lead gen, I suppose, would be that kind of, they're clearly very interested, why don't you have a conversation. What we haven't got at the moment, because we haven't gathered it, is direct, came into ORCHA and won this contract as a result, because in most cases we would never know if, for example, with some of the ICBs that we've worked with for 5 or 6 years, they require a product to be in ORCHA to be able to deploy it. But obviously what we can't prove unequivocally is, because it was in ORCHA, it was commissioned, or this contract was won. They've probably, the likelihood is they've just checked that it's in ORCHA and so they're happy, but obviously we would never be privy to that. So it's something that I really agree that if we can demonstrate that, I mean, you then go down the ROI route, right? It then becomes much easier. My job becomes a lot easier.
So in terms of sort of the service provided, there isn't a kind of like a reach out to organizations to say, I can see you've got your commissioning for the following services, and such members meet that criteria. That's not available as yet.
Not directly commissioning opportunities. What we will do as soon as you've passed is we will look at where in all of the sites that we're supporting is the product relevant. So, I mean, obviously for you guys, I'd imagine it's going to be probably 99% of them, because everybody has a focus on either, all of our mental health support kind of organizations have a focus on getting people more active as a very direct correlation to mental health, right? So it's never just a case, like, with Mind UK, for example, it's never just a case of, if you're not supporting anxiety or depression, then you're not going to make the cut. It's actually more, all the sites are far more holistic than that. So what we will do is say, right, you're very relevant to this folder at NHS Dorset, you're very relevant to the work we're doing in HSCNI, Cheshire, Merseyside, whatever, and we'll push you out across those sites. We essentially can do that without the client, needing to approve it, because they set criteria for what features on their sites, not selecting specific products. So, like with NHS Dorset, we'll say, by the way, there's 3 new products that are going onto your site this month because they've met your criteria of, a risk profile of less than level 3, a score of over 65%, etc. So we will do that bit, but obviously it's not necessarily a commissioning decision, it's a visibility thing.
Gotcha, thanks. I've got many more questions, but I'll leave those when we.
No, that's fine. And I have put another Q&A in at the end, but we could, we're long overdue a catch up anyway, so that's not a problem. I shall kind of fire through a few of the slides, because lots of this wraps up into all of the platforms that I've just shown, and I always think it's nice to kind of show the scale of where these platforms are actually being used, not just simply that they exist and we've built them. So obviously I've talked a lot about things like Mind, our NHS trust providers, touched a little bit on some of the US associations that we're supporting as well, but also right down to individual councils, and in some cases we're one of the ones that isn't on there, but that we work with very closely in the Midlands. We are commissioned by a specific substance misuse team, where they actually want the ability to e-prescribe digital as part of every patient interaction. So the breadth of access is something we tried to look at the numbers, and it sounds like a marketing statistic, but it's something like 500,000 clinicians could access an ORCHA site if they wanted to. A lot of that coming from some of the new associations in the US, so like the APA, for example, with 150,000 registered psychology professionals across the US. But again, about driving that visibility, and obviously ever growing that 620,000 unique visitors that we've had over the last couple of years. That's kind of what we're always vying for, and what we're always trying to achieve, above and beyond let's just assess every app on the planet, because that would be tedious at best. Obviously, again, and I've kind of wrapped a lot of this into the demos because I think they're far more interesting than talking at length around slides. But fundamentally, the kind of fast track routes to adoption via ORCHA cover 4 key channels. Directly to populations targeted via the likes of CareQ, where we're working to ultimately digitally enable patients. Going via those professionally supported digital health formularies, giving those professionals the confidence that actually they can recommend these digital technologies because they've been validated, because they're safe, and because they're in an environment they can access easily. You know, that's part of the reason why the formulary took us 2 years to achieve all the integrations across various health record providers, because we learned very quickly that if you give, particularly in general practice, if you give a GP another clinical system that they've got to...
Right, the patient's saying they've changed the list.
Got a bit of feedback, we'll just do a mute there. Obviously, you know, particularly in general practice, if you give a GP another digital system that they've got to either log out of their health record to log into, or that they've got to go into their browser or that kind of thing, we know that that creates another relatively significant friction point in terms of getting them engaged. And the response I've had from many GPs is that basically the only way they'd use it is via the integrated platform. You know, they wouldn't use it as a standalone, because although it might only be 2 minutes for them to go in and do that, actually that's 2 minutes they don't have with that patient. So really interesting learning from our perspective in terms of actually really embedding that into the kind of existing workflows. The trusted repositories bit, ultimately, that is the ORCHA Compare platform. That's 2,500 products that are currently in the ecosystem that have been assessed against the latest version of the baseline review criteria, and the other 6,500 that have been assessed against the previous version that haven't come forward yet. And then the direct distribution via those channel partners is the likes of Mind, where ultimately they want to be able to better support their patient populations, their visit. In the case of Mind, as simple as the visitors to their website, they want to be able to actually get those onto some level of support that is above and beyond an electronic leaflet, some generic advice and guidance, and Mind has been a fascinating project. I think last month it was something like 12,000 unique visitors went to Mind's digital app library. It was the highest we had on record for a single site. That actually people are actively searching and looking either for a specific product and searching for a product they've heard of. It might be a Headspace or a Sorted or a Weiser or whatever, or looking for something more broad and not actually knowing what specific technology they're after. I'm going to skip a couple and look at, particularly around CareNav and that distribution side, how that can really support in general practice. And for me, it's as much about giving general practice a new way of thinking about digital, in that digital is not their electronic health record, it's not their appointment booking system, it's not the fact that they have to have e-consult or similar turned on for longer during the day now. It's actually about digital to support the patient in the ideal setting, so that those that don't actually need they don't need an appointment, they can better self-manage, actually giving them that power. So from a care navigator's perspective, every GP practice and network I talk to, their biggest stress is the 8 a.m. bottleneck, and how they actually manage that, how they try and get the patients in, how they prioritize which patients actually really need an appointment versus those that could have that advice and guidance. And in the use case there, patients looking at a patient struggling with their mental health, no appointments available that day. Such a common occurrence across, particularly around, in my local area. Actually, the care navigator can say, why don't you go and have a look at the online app library? They can send them a direct link through their e-coms platform, so that the patient doesn't have to try and search, doesn't have to go and search, that kind of thing, and so that ultimately the patients that are actually in crisis and really need to be in front of their GP have kind of got that option. Second route, again, the digital health formulary is the integrated version. You've got a patient sat in front of the GP, hesitant to go straight onto medication, and again, a very, very common occurrence from the GPs I've spoken to recently. And actually, they know if they're on a waiting list for therapy, that could be 4-6 months if they're lucky. And again, heard some horror stories of it being much longer. But actually, from within the health record, the GP can provide them a digital technology to help them with managing their anxiety, either while they're on the waiting list in the first instance, but actually, if it's effective, there's every chance that might reduce that patient's need to be on that waiting list, or ultimately take them off it altogether. And then the automated population health campaigns are that new evolution, where actually we can take, looking at frequent attenders as a really core group, that ultimately, if they were digitally enabled, we did some research last year, that if you could digitally enable 3% of your frequent attenders within primary care, in your average primary care network, it would free up over 2,000 appointments a month. So really, really phenomenal opportunity. And again, managing them in this setting, unmanaged mental illness, might be sat on a waiting list, might be struggling and just turning up once a week because they need that support. Actually, we can do a targeted campaign based on their specialty codes, within the health record, to say actually all of these patients are very relevant to digital mental health, managing anxiety, these kinds of things, and making sure that we can target them with something that's highly relevant, or potentially even, in some of the areas we've spoken to, they've already got a digital technology that they've actually commissioned, but haven't got the route to actually deploy it to those patients. So really being able to support that journey as well, and hopefully support the organisation to keep the technology commissioned, as opposed to not seeing some of that impact. Now, this is a really, really busy slide, and I apologise. I was saying to Indy before everybody joined that this is a horrendous slide because we haven't finished the nice version of it yet. But I will send a copy of this out afterwards, so don't kind of feel the need to go through and try and read the ridiculously small writing. But just really focusing on some of those other markets, and I don't know how many of you guys, and I'm sure we can get into some one-to-one conversations over the next few weeks, where you guys are really working and what markets you're trying to break into. But certainly for us, the US is growing really, really rapidly in terms of those distribution channels and unlocking some of those opportunities to get out in front of either specialist clinicians or direct to patients as well. And some of these I'd already talked about. So the likes of the American Physical Therapy Association have a library of MSK and broader wellbeing technologies that is available to over 100,000 members of their association. And ultimately they can then e-prescribe those. They can use that for due diligence, or they can in some cases actually use that as a tool to find the right technology that, as an organization or as a local provider, they want to engage with. I'm not going to read through all of them because people will get bored. But again, I've talked about the APA as well, with a phenomenal coverage of mental health professionals across the US. And again, there is a specific assessment that APA have to go through. Rather confusingly, they've established their own bronze, silver and gold APA accreditation, which has caused a little bit of confusion with the ORCHA Assured. But in both instances, they're ultimately delivered by us and provides a phenomenal channel to get those products in front of ultimately if you're a mental health product, in front of your end user and your end buyer. And again, I must have talked very quickly because I'm a little bit ahead of time. To kind of wrap up on how we work with you guys, and obviously I've talked about some of the subscription stuff and how a lot of that works, but it starts from £100 a month for the ORCHA Assured subscription. That's the entry point to be part of the ORCHA ecosystem and be part of most of the opportunities, particularly across the NHS. That's your starting point. There's no additional cost if you're in X number of sites, X number of visits, visibility, all of that kind of thing. With some of the schemes that we've established, so Mind, APA, etc., there is an additional cost. There is a membership for the scheme that goes back, that ultimately is paid to them as an institution. And happy to share a bit more on some of that one-to-one if anybody is interested. But that's me stopping there, way ahead of time. I must talk too quickly, Indy.
No, I think that's good. That I've covered lots of stuff there, so probably lots of thought for people to kind of try to digest. You have offered the one-to-ones, and I know a few people will be keen to kind of take you up on those. So I'll probably ask colleagues to send me some details of their availability. Or Jordan, would you like to send me details of your availability, and then I can send it out to the rest of the people?
Yeah, I can send over. In fact, let me just see if I've got. I can paste my meeting link into the chat, so rather than trying to knock back and forth, if that's easier for people.
Yeah. Okay. So if you do that, put the meeting link in, and then people can take you on that one-to-one. I suppose, there is the regulatory side, there is the actual various libraries and exposure that ORCHA can provide. And I suppose for all the companies that are on the call today, it's a case of trying to establish where it would be most suitable for your company and organisation and product. And those one-to-ones would probably be a good way of trying to identify that if you haven't done already. I suppose it's probably opportunity just to ask any more questions if anyone's got anything burning that they want to kind of go through now, rather than on a one-to-one. Go on, Kevin.
Yeah, can I ask, thank you, and apologies for missed, so you may have covered this, so apologies if I missed that while I was away. How much, I can see the value of a platform that assesses lots of different digital applications and products and certifies them in different ways. There's also like the blueprint system within the NHS that looks at certain things that where one NHS organisation recommends to others ways of doing things or products. How much does the ORCHA certification enhance the viability or the willingness of NHS organisations to purchase a product over people that aren't ORCHA certified? Do you have any data on that?
So a really great question, and a very similar question to Simon's, but not exactly the same. So the key thing with the NHS will be that to be commissioned by the NHS, the thing you will need is DTAC. So the NHS across the board, again, I'm always very transparent, will not tell you need an ORCHA Assured assessment, or you don't need. In some cases they'll mention it, in some cases they won't. In the areas that we are working very prominently, like Cheshire and Merseyside, across the Midlands, down to Sussex, Dorset, etc., where we've worked with them for many, many years, it's a relatively standard part of their process now to ask for that ORCHA Assured alongside DTAC, or as part of, in some cases, an early engagement. The extent to which it enhances your kind of procurement conversations, for example, because it's foundational, it doesn't cover the same breadth that things like DTAC do. It's not going to be the difference between ultimately you being purchased as part of a procurement and not, because if you've got DTAC, you've got the criteria of the baseline review, if you see what I mean. DTAC wraps it all up together. what it drives is the visibility pre those kind of procurement conversations. So, via things like the Compare platform, where often the health systems don't know what type of product they're looking for. They don't know exactly what they need, but they will have a defined use case. So, the mental health example that I gave, they will know that they need a mental health product to support this patient group, and they have to have, they had to have that embedded earlier this year. Actually, what we saw was a huge spike in searches around mental health, because actually they didn't know what was available. They didn't know the types of solution. What they will then do, particularly if it's part of a commissioning decision, is say, right, we found you through the ORCHA ecosystem. We now need to see your DTAC.
Yeah, I mean, that's one of the things I can see that one of the biggest values is like you're providing a comprehensive catalogue of available products to fit a niche market. And on the DTAC side, I presume if you've got ISO certification, then that's kind of covered off anyway, isn't it? Really?
So 27001 is part of DTAC, but obviously DTAC is far broader than any ISO standard. So DTAC is one slice of that kind of pie, as it were, but obviously things like clinical safety, DCB documentation aren't wrapped up in an ISO standard as such. Even some of the technical security stuff, there are established ISO standards, but for the NHS you need Cyber Essentials, you need a penetration test done in the last 12 months, that kind of thing. So there isn't an ISO standard that directly replaces or overlaps with DTAC, with the exception of 82304 Part 2, which is the ISO standard for digital health that nobody's ever heard of.
I've never heard of it. So
so that was a 3-year project across Europe that we were very involved in, and is actually built on top of our baseline review as its foundation. Development was funded by the European Commission, and that includes clinical safety, clinical efficacy. That does bring in, as a standard, a number of elements of DTAC above and beyond 27001 or those kinds of things. But massive asterisks that 82304 Part 2 has not been adopted anywhere. It exists as a standard, and you can go onto ISO and you can buy the spec and all that sort of stuff. It hasn't been mandated anywhere. So it was a bit of a strange project, in that it was 3 years of work and nobody's used it since.
All right.
And nobody's ever heard of it.
Okay, thank you.
You're very welcome.
Okay. I suppose one question for you, Jordan, is you mentioned like Cyber Essentials and pen testing. Is that something that you guys offer, or do you signpost out? Or
so we have a whole range of partners that we can refer to for things like that. So it's a question we get asked all the time, and ultimately the reason we don't do writing clinical safety documentation, we don't do pen testing, we don't do any of that in-house, is that in many cases we are commissioned by the NHS to deliver independent assessments. And so we've always felt that we can't be the ones to write a DCB 0129, for example, and then be the ones to say, yep, that's valid, that's that's accurate. There's a relatively clear conflict there. But we have a whole range of partners that we can refer across to, typically after that DTAC gap analysis piece, to say, actually, this is the support, this is the support you're going to need. These are the partners that can help you with that if you need to. Okay,
so I also know people that can help with that if any of you guys need some support in terms of pen testing and the Cyber Essentials. Okay, any other questions, burning questions? So Jordan has put the link into book in the one-to-ones into the chat. As I assume everyone's been able to access that. But if there's no other questions, I just would like to thank Jordan for his time today and going through all the important elements that ORCHA can provide to your innovation journey. Also to thank you all for your time today, and hopefully you've taken something away from the session.